Do I worry about contralateral hematoma after craniectomy, and what's the protocol for CT after surgery? Always worry about contralateral hematoma, and that's a great thing to think about. Protocol for CT after surgery depends on the patient. So if there is somebody had a case like just the other day, somebody came in with a very large contusion that blossomed, and so he was getting a mass effect from the contusion, but he had a subdural hematoma on the other side. So we were very worried that once we took the bone off from the subdural, or from the contusion, excuse me, that the subdural would expand because we've released the tamponade. So in that case, it's immediately, once we're done with surgery, we go to the CT scanner on the way up to the ICU. Anesthesia gave us all this pushback. We said, nope, absolutely not. We're not going to the ICU without a CT scan. So we went straight to the CT. Surgery goes great. If I think that, if I'm not worried about another side hematoma, if the surgery goes fantastic, and it was just a clear subdural, with no real complications, even more so if they can get the patient extubated, or if I get a good pupillary or neuro exam after the case, then we'll go up and we'll get a CT scan in 4 to 6 hours. So it really depends. It's a case by case. There are no standard protocols for a lot of this. You have to be able to think on your feet and use some common sense. So in traumatic brain injury, when we're dealing with a subdural, there's a number of questions we have to answer, right? So things like, are they going to go to sorry about that. Are they going to go to the ICU? Are they going to require anti-epileptic drugs? Are you going to have to reverse an anticoagulant or antiplatelet drugs? Are you going to put in invasive neuromonitoring? And are they going to need surgery? So we already talked about the indications for surgery. That one's pretty straightforward. So let's talk a little bit about these other questions. So ICU admissions, do all subdurals need to go to the ICU? Well, no. There's some good data out there showing that a lot of these patients are not at a significant risk to decline. And you'll start seeing this when you're on your neurosurgery rotations. You'll get called about every little tiny blip of blood that's in the head. And some of these little tiny blips of blood, a lot of these little tiny blips of blood are not going to do anything. They're not going to explode, and they're not going to ever cause any sort of problems for the patient. So this article here, what they did is they made what's called the BIG protocol, where they divided patients into these 3 categories, 1, 2, and 3. And you can read the criteria to fit in each one here, but for a subdural, if it's less than 4 millimeters, and they have all these other inclusions, then they're what they call the big one. And they would not admit the BIG 1s and 2s to the ICU. They would just get a repeat head CT, and not admit them to the ICU. And in all honesty, almost all of them did fine. I think there was one patient that declined, but they had some other injuries. So really, a lot of these do not need to end up going to the ICU. You just get a repeat head CT and go from there. So I encourage you to read this paper just to get an idea of the sort of things that would make you on high alert. Anyone that has these criteria for the big 3, they go to the ICU and they're going to need a repeat head CT. This paper, there is a little bit of issue that I personally have with it, and that is that they also advocate for not even calling neurosurgery for patients with the big 1 and big 2. And I think that's a little bit troublesome because of this, and this is what I mentioned, the stat that was literally just published the other day, is that 47% of individuals over 40 years old in the US with a history of head injury have a disability. 11.4 million people in the United States have some sort of disability from a head injury. That's a lot of people. And these patients need post-acute care support. They need help getting back to work. They need help to make sure that they don't develop drug and alcohol addiction, which tends to pop up in TBI patients. They need help to make sure that they are dealing with their post-concussive symptoms okay. And if you're not calling neurosurgery, you need to make sure that somebody in the medical center is taking care of these patients, be it neurology, be it trauma surgery. But neurosurgery, we're the specialty that's tended to deal with traumatic brain injury the most. So I think we're probably the most set to take care of these problems, even if they're not surgical. So this is just a personal bias. So I really think that if you're going to take this criteria and not even call neurosurgery for most of the head trauma that comes in, I think we're doing a little bit of a disservice to the patients unless you have those post-acute services really set up for them. So there's my own little personal soapbox of bias, but it's a huge disease burden. Anti-epileptic drugs. This is the classic study. Know this study. This is one of the big papers in neurosurgery where they randomized people into phenytoin or placebo after traumatic brain injury and showed that on early post-traumatic epilepsy, phenytoin was significantly better than placebo in preventing seizures. So Everybody with a subdural, a contusion, and epidural gets 7 days of phenytoin in our institution. I know there's some data with Kepro. The data is just not as good, we don't think. So we like using phenytoin 7 days. It's a relatively harmless drug. It's a cheap drug. It's an easy to monitor drug. So we do that for 7 days, but it does not prevent late seizures. So 7 days of phenytoin to prevent early seizures and then stop. And that's the study for it. Are you going to reverse antiplatelet, anticoagulant agents? This is a big question because people are living longer. You're getting more and more what my boss calls the silver tsunami, which is just a lot of old people walking around there on Eliquis, on aspirin, on Plavix, and they're going to come in with traumatic brain injuries. And what do? Are you going to reverse the Eliquis or the warfarin or the Plavix on everybody? And I'm not a fan of that. So this is a busy slide. Oops, sorry. It's a busy slide, but this is the study if you really want to look up what the Neurocritical Care Society has as their recommendations. It's a little bit outdated, and I'll get to that in a second. But really, the thing I try to drill home in my residents is that I don't want you just knee-jerking and reversing the anticoagulation on everybody. If they have a really small intracranial hemorrhage and they have a high risk of having a thromboembolic event, say they have a fresh stent, or they have really bad AFib with a high CHAD score and a history of stroke, if they have a recent PE, something like that, if they really need their anticoagulant medication, you don't always need to reverse it. So use some clinical judgment. Don't always reverse it. Don't always even hold it. Talk to the patient, talk to the family and say, there is a risk if we hold this medication that they're going to have some sort of thromboembolic event. There's a risk if we don't hold the medication that their intracranial injury could become severe. But it's not always a knee jerk. If it's somebody like our guy in our case earlier, if he was on warfarin or something, he had that big subdural, absolutely I would hold it. But if he just had a little speck of blood in his head, maybe not. So it's not something that should be a knee jerk reaction. And that's kind of what they say here. So for antiplatelet agents, if there's neurosurgical intervention, then you consider doing a platelet transfusion. But everyone who's on aspirin that comes in with a head bleed, they don't all need a platelet transfusion. That's risky. That's going to use up the nation's supply of platelets. For somebody who's, say, on enoxaparin or unfractionated heparin, if they, say, have worsening bleed in the hospital, you don't always need to reverse it. If it's been more than 12 hours since their last dose, you can probably just go forward without reversing it. So, use a little common sense. Don't just use the knee-jerk reaction of reversing all anticoagulants. And then, like I said, the original paper is a little bit dated because there is this new drug that specifically reverses some of these factor 10A inhibitors. So it's the data is kind of equivocal. Some people advocate using it. Those people often ignore the fact that it's a highly expensive drug, but it is something you can use if somebody comes in on these factor 10A inhibitors. Neuromonitoring. So what do we monitor when we say neuromonitoring? Does that mean ICP monitor? Does that mean a Lycox? Somebody that monitors brain tissue oxygenation? Does that mean a cortical electrode that monitors for seizure activity? These are all terms that fall under this kind of big bunch of neuromonitoring. So we do neuromonitoring just by monitoring the patient's neurologic exam, right? If we're checking their pupils and checking their neuroexam once an hour, that's neuromonitoring. We monitor electrophysiology. We monitor ICP, CPP, and systolic blood pressure. And then this is my version of the Monroe-Kelly doctrine, which is the brain is a contained space, venous blood, arterial blood, brain, any mass, and the CSF. I'll get to this in a little bit. We can monitor oxygenation, like I said, with brain tissue oxygen monitors or with jugular venous oxygen monitors. And we can even monitor, the brain's local metabolism using microdialysis catheters.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.